I'm going to introduce all three panelists now in the order that they will speak, and then I will invite them up to deliver their remarks. So, Ross Baker is professor in the Department of Health Policy, Management, and Evaluation at the University of Toronto, where he teaches and carries out research on patient safety, quality improvement strategies, and leadership and organizational change. Along with Peter Norton, he was awarded the Health Services Research Advancement Award for his work on patient safety and quality improvement by the Canadian Health Services Research Foundation in May 2009. He co-chairs a working group on methods and measures for patient safety with for the World Health Organization, and chairs the Advisory Committee on Research and Evaluation for the Canadian Patient Safety Institute. In August 2010, he accepted an invitation to serve on King's Fund in London's Commission on Leadership and Management.
I want to thank the Baroness for really a wonderful sort of update on what's happening in the NHS and the UK more generally. And you can tell this is a complex arena, right? Lots of particular elements that you need to know to appreciate these changes. And what I want to do is say a little bit about those changes, but I really want to start with painting a bit of the context of where the NHS has come to while these changes are hitting it, because I think it's really important to see that in order to reflect on what the impact of these changes might be. We need to recognize what they've accomplished in the last decade. Under the Blair and Brown governments, they really substantially transformed the NHS. And it wasn't worst to first, but it was pretty close to that in terms of advanced systems. And Don Berwick had a nice piece a couple years ago where he said, looking at improvement work in the US and improvement work in the UK, he said, in the improvement horse race, bet on the UK, that they were making faster strides and moving forward in ways that seemed more sustainable than his colleagues in the US. It would be interesting now that he sits in the American government to go back and ask him that question about how he feels. I suspect he might say the same thing. So what do they do? Well, I mean, we know this bit about the targets and the extent to which efforts were made to reach those targets, and I don't think we can underestimate the extent to which life at the front lines has really changed in much of the NHS. I mean, the 4-hour A&E target, the 18-week GP to surgery target, the 48 hours from call to appointment with GPs, I mean, those are remarkable changes, and they don't give you the full flavor of this because now the average wait, I just looked this up, the average wait for admitted patients in hospitals to surgery is 4 weeks, down from nearly 15 weeks a little over a decade ago, and 2.5 weeks for patients who are just coming in from outside of the hospital. That's enormous change, system-wide change, all areas of surgery. And it's not just waiting times. We focus mostly on the waiting times. But in the patient safety world, the work in the UK has been really seen as groundbreaking kinds of work. And I'll come back to talk about that a little bit, because one of the casualties of these reforms is the loss of the National Patient Safety Agency, which is seen by many people as sort of a leading example of how to do this work in a complex system. So patient safety issues have moved, and a variety of other quality metrics. And the Commonwealth Fund, which every year does these surveys in now 7 countries, asking patients about various aspects of their care, and then produces this interesting league table where it rates the 7 countries, including Canada, the United States, the UK, Australia, New Zealand, now Germany, and the Netherlands. The UK now ranks 2nd. Canada ranks 6th. The UK spends $600 less, US dollars less per year per capita than the UK. The US spends twice as much as the UK, and they rank dead last. So we can't underestimate, where they've come from. And we have to ask the question, how did they get there in such a short period of time? And so here's my list, and of course there are many other things. First of all, major investments in capital infrastructure, personnel, and IT. They bought a lot of things that they didn't have before. And they bumped health spending from 6.5% of GDP to 9%. They put primary care at the center of all their changes, and that historically has been a strength in the UK system, something that I think we continue to look at with envy, because most of our changes have not happened in primary care, and it's only recent in Ontario that we've had these sort of substantial, I think, improvements in what we see in primary care. They established clear accountabilities, and they acted on those accountabilities when people were unable to perform to meet the targets. And there's a lot of stories about blood on the floor when chief executives were called to account for not meeting various targets. And on the other side of that, the flip side of it, it wasn't all top-down. There was an enormous attempt to really build skills, build capabilities, build the system levers to allow people to make changes locally. And I think that's really important and underestimated. Yes, they stress the system. Yes, they really push people to perform. But at the same time, they were giving large numbers of people, probably the largest training program anywhere in the world in terms of quality improvement, lean skills, and so forth. And then they created a whole bunch of mechanisms to allow people to put that skill in use. So the national service frameworks, large-scale collaboratives in many different disease areas, cancer, cardiovascular disease, and so forth. And I had the opportunity 3 or 4 years ago to spend a week in Birmingham, which we had picked on the advice of Helen Bevan as one of the sort of high-performing areas. And we were frankly really amazed at the level of engagement of staff, the focus of leadership, and most importantly, the partnership between the primary care trust and the hospitals. And it was something that you would rarely see in this country, to have that sort of level of engagement and a sense of needing to accomplish common goals, even though they had specific responsibilities that sometimes rubbed against those common goals. So many things that they achieved. So these current changes need to be seen in that light. And this massive cut in the expenditures, while at the same time they say they want to hold the quality gains that they made, and I have some doubts about whether they're going to be able to do that. Now, there's some positive parts to this. They're maintaining, in fact, strengthening the role of NICE. They're increasing the focus on public health, which is one of the areas in which the English system has not done as well as it probably could be in international comparisons. They're improving patient choice, and they're keeping the GP at the center of the system. But the radical and rapid changes that they see, I think, are really more than they can deal with in the short-run basis. And this sort of desire to take everything up and turn it over, shake it up, and sort of see where the parts fall out is not new. As the Baroness said, I mean, they've been through this several times before. And Alan Maynard had this wonderful phrase where he said that we'd like to have periodic re-disorganization of the NHS. and he said that, you know, the NHS scores 8 out of 10 in bright ideas and 4 out of 10 in implementation and execution of those bright ideas. But the key here is execution, right? Having a great idea doesn't get you anywhere unless you can actually find the people on the ground to do it. And Lord Darzi in 2008 wrote this really flagship report reporting on these changes in the NHS and saying high quality care for all, which Jim Easton pointed out is not as ambitious as the Ontario agenda, which is excellent care for all, but still reflects a lot of energy and a lot of effort. And Darzi said in his report, he said that quality care cannot be mandated from the center. It requires unlocking the talents of frontline staff. So now we face a current situation where we're taking massive amounts, up to 20% of the budget out of the NHS, and looking to dismantle some of the key parts that really have been part of, I think, the ability to create the local capacity and to execute on change. The National Patient Safety Agency has been a whipping boy in England for some years now and was castigated by the Public Accounts Committee a few years ago. They invested massively in a reporting and learning system which has more reports than any other system in the world. Unfortunately, they can't turn those reports into local advice. And if you talk to the NPSA executives, they say that's because the NHS and the Department of Health wouldn't let them do it. The issues were too sensitive. And if you talk to people on the other side, they said that's because they weren't able to provide advice that was useful and able to put it into widespread use. Okay, so one of the issues here is around how do you actually continue to make change when you've sort of decommissioned important parts of the system. Besides the Patient Safety Institute, the NHS Institute for Innovation and Improvement, which was a downsized version of the Modernization Agency, which really led them through the first stage of a lot of these changes, also is on the chopping block. And although the official word is that elements of that will be incorporated into other bodies that are created, much of the energy will go into figuring out who does what, to whom, how, and with what money, instead of actually continuing on the work of supporting the front lines. The other issue which I'd be interested in the Baroness' view on is the changing roles of regulators here. The regulator for the Foundation Trust monitor now has this bigger role, but it's primarily an economic role. The Care Quality Commission will continue to have its role, focused on quality and safety issues. And then you have the NHS Commission Board, which is helping to set other sorts of agendas for NHS trusts. So how will they act together? How will they coordinate their activities? And what will the NHS leadership at the trust level pay attention to? Who will be setting the sort of lead on these kinds of critical issues as they move forward? So let me stop there and just say a few things about how I think this applies to Ontario, because that's where it really takes root. And the first observation I'd have is structures do matter. Structures do matter. And we sit here, you know, with the LHINs in place, with the hospital boards still fully functioning, with primary care still not fully formed, I would say, and capable of executing the agenda. And we need to ask the question, what are the right structures to help us to bring those pieces together and to really create a more integrated care delivery system, recognizing the fact that it's more of a chronic care issue. It's more about dealing with the needs of people on an ongoing basis, and less the sort of episodic acute care environment that we've seen before. We know that structures, when they're dismantled badly, can have important implications, and we only have to look to Alberta to recognize what's done to undo a lot of, I think, really excellent work in some of the regions there moving forward. The second lesson I take is this notion that capacity building and support are key. And I'm really heartened by the fact that we've seen increased investments in quality improvement work in this province, really scaling up this kind of initiative over the last 5 years, and with the promise of, I think, more to come. The issues that we face now are big issues. They're not just issues in the silos, they're issues across the silos. So we need to create a means to start to address those issues about transitions of care and avoidable hospitalizations, chronic disease management, and patient safety. And the last issue, and I'm looking at Mark as I say this, is this issue about leadership. Leadership is the critical element in all this. You can have the best structures in the world, the best processes, and if you don't have the leadership to actually turn it to on-the-ground reality, you can't get anything done. And that's almost trite to say that, but I think what I fear is that in England, we'll see a disillusion with the current status quo, and many people who fought these battles and can return to fight the battles again will say this is just too much. And so the NHS leadership and management is really the critical element that's going to help to make this happen. Oh, but by the way, they're being cut 45%. So what are they focused on? They focus on maintaining their jobs, figuring out how they fit into new structures, rather than continuing this focus on quality and patient care. Mark.
Thanks, Ross. Appreciate it.